I'm Sam Johnson-Scott. I'm a member of the GFF results team, and I'm also a health information systems specialist. And rather than use simultaneous translation, what I'm doing today, I've produced two versions of this presentation, one in English and one in French, so that you can watch the presentation in whichever language you prefer. So the topic we're going to talk about today is health information systems, or HIS. I'm going to start in this first section by taking you through a wide range of different types of health information systems so you can better understand the differences between each type of system. And then in the second half of the presentation, I'm going to zoom in on three particular types of health information system, three particularly important ones, which are HMISs, electronic medical records, and trackers. This is a really wide and complex topic, and it can often get very technical. It doesn't help that we as specialists working in this field use a huge number of different acronyms. I'm guessing that some of these will be familiar to you, but I'm sure that others will be quite baffling. So don't worry if you don't recognize quite a lot of these. You are not alone. I think that if you already know what even just 5 or 6 of these acronyms mean, then you're doing really well. So what we want to do in this introductory presentation is take this very broad and complex topic filled with acronyms and try to give you a simplified overview of it all to try to make all of this more accessible to non-specialists. I've already talked a lot about health information systems, but what exactly are they? It's important to note that there isn't a single definition that's accepted by everyone. The use of this term can differ from one person to another, but in general, it describes everything involved in the collecting, processing, and importantly, use of data for health sector decision-making. And by decision-making, we mean everything. We're talking about sector-wide planning decisions, right down to decisions that affect the care of a single individual patient. This includes all aspects needed for the collection, processing, analysis, dissemination, and use of data. We're talking about governance. We're talking about the people involved, the actors. We're talking about the processes that are put in place, and obviously the tools that are used. But it's important to emphasize that we're not just talking about tools or software. It's all of these different elements that make up a health information system. And one last point, it's important not to confuse the health information system, or HIS, with a health management information system, or HMIS. As we'll see shortly, the HMIS is just one type of system within the overall health information system. Because the HIS is a huge topic, for our discussion today, we're going to narrow down our scope a little. So firstly, we're just going to focus on routine information systems. We're not going to cover surveys and other periodic data, even though they are normally part of the health information system. Secondly, we're going to focus on 5 principal domains. We're going to look at health services, medicines and supplies, human resources, finances, and finally, civil registration and vital statistics, also known as CRVS. One final note before we take a look at the HIS landscape. The aim of this presentation is to give you a simplified overview of health information systems. It's a bird's eye view of the landscape. But as such, we lose a little bit of precision. We lose a little bit of detail. So it's important to note that these are broad brushstrokes, and sometimes a little bit of detail or precision might be missing. Similarly, some of the terms used in this presentation, as we mentioned already, don't mean the same thing to all experts. So where there are disagreements about the definition of a term, we'll note this and we'll explain the choice of definition that we're using in this presentation. So what I want to do is start by setting out this bird's eye view of the overall health information system. And we're going to focus, as I said, on these 5 key areas. As we go, I'm going to give you some examples of the tools that are available for each type of system, open source software and things like that, just so you can understand where they fit. You may have heard of some of them and want to understand where they fit in this landscape. But remembering always what I said before, that tools are just one part of a health information system. The health information system is everything, the people, the processes, the governance, all of that also makes up the HIS. So to start with, one that you're probably very familiar with, HMIS. This is usually a sector-wide information system that gathers all of the data needed to really manage health services across the entire sector. And a good example of a tool that's used in a lot of countries for this is DHIS2. So DHIS2 often is the main tool underpinning the national HMIS. A second type of system we want to look at today is an electronic medical record, or EMR. Now here we're at the opposite end of things. Here we're talking about inside the facility, really getting down to the level of patient care. So these are really systems that frontline staff use to manage interactions with individual patients. As we said, remember, the decisions that we're talking about in HIS could range from anything from big 5-year sector planning decisions right down to the decisions that a doctor makes about an individual patient's care. And that's where an EMR comes in. So examples of electronic medical records, these are all open source examples, include OpenMRS, BarnMe, and OpenEMR. You may have heard of some of these, but actually there are hundreds of different types of electronic medical record. And sometimes an individual hospital will even develop its own little system. The next one we'll look at is trackers. These come halfway between an EMR and an HMIS. They do normally track patient or other more detailed data, but at the same time, they're much, much simpler than an EMR and tend to be based in the cloud and more likely to use mobile tools like a mobile phone or a tablet, something like that. They're much, much simpler than the EMR. We'll go into examples of these a little later, but examples of tracker systems that you might have come across. A common one is Comcare, another one is DHIS2, which has its own tracker built in. And you also might know the Community Health Toolkit, which is used for community health workers to help them track individual patients. Again, much simpler than an EMR, but we're often still tracking individual patients. So moving across to medicines and supplies, we've got an LMIS. You may have heard that term. Over the past couple of years, LMIS are really being rolled out in a lot of places. And LMIS is a logistics management information system. So that holds information about all of your drugs and stock. And it's really designed to manage it from the national warehouse, the distribution, all the way down to individual facilities to make sure that your stock is getting there. Examples of open source LMISs are OpenLMIS or Logistimo. And you may have one of these systems in your country. You might also find for medicines and supplies that you have a pharmacy management system. Now, this isn't about national distribution between warehouses and facilities. This is inside the health facility. This is how a pharmacist can manage prescriptions to individual patients. You might also find that your HMIS collects some data on medicines and supplies. For example, some HMISs include tracer medicines that need to be reported at the end of this month, but this won't be for detailed management of stock. This is more to give you a management overview of where, for example, there might be shortages in clinics. And it's normally very, very simple. An HMIS won't collect much data about medicines and supplies, just the key headlines for management reporting purposes. And finally, both EMRs and trackers can cover some aspects of stock, as we can see here. For example, an EMR might have a module for patient prescribing and a simple stock management function. The next domain we'll look at is human resources. And probably the most important type of system here is an HRIS, or Human Resources Information System. This exists in some countries, but not all. It's quite a difficult system to implement and maintain. So this can capture everything from individual records of the staff working in facilities across the country, right through to big picture workforce planning. You know, for example, how many new nurses are coming out of training versus what the workforce needs are. It essentially covers all aspects of planning and monitoring human resources. A good example of open source software for this is Iris, which has been deployed in quite a few countries. You'll find though that an HRIS doesn't look at day-to-day HR functions like payroll, salaries, pensions. This day-to-day work will normally be done using a different system, probably not directly owned by the Ministry of Health. It might be the Ministry of Public Service or another organization. And that's where those day-to-day HR functions are managed. And like medicines and supplies, your HMOS might collect some data about human resources. But again, this will usually just be something like total numbers for key types of worker, of health worker. In other words, very, very simple HR data, not the comprehensive data sets you get in an HRIS. The next domain is finances. And a key type of system that we've seen in more and more countries is an IFMIS, or Integrated Financial Management Information System, which pulls together in one place all of the disparate financial information that traditionally has been held in lots of little silos here and there. At a much more strategic level, we also have resource mapping, where rather than just looking at the government's own finances, what we're trying to do is get a handle on, say, an annual basis, get a handle on all of the resources in the health sector, and where possible, doing regular tracking of disbursements and expenditure against those resources. And finally, alongside these systems, you'll also find traditional accounting systems which manage, day-to-day payments and other transactions. The final domain we'll look at is CRVS, so the Civil Registration and Vital Statistics. And the first component there is civil registration. And here, the civil registration systems can be quite weak in some countries. They're either paper-based or electronic, but these essentially manage the registration and certificates for vital events like births, deaths, and marriages. And drawing heavily on these civil registration systems, we have vital statistics, which is, compiling and analyzing this data to give us up-to-date statistics like birth rates, maternal mortality rates, and things like that. And the reason these are critically important is that otherwise we depend on surveys which might only come out every 5 years or so. These give us relatively up-to-date statistics that we can monitor much more closely. An example of a tool for an open source tool for CRVS is OpenCRVS. This is still in development, but it's a tool that's available for that. So we've seen those 5 different thematic areas, but there are also a couple of other dimensions that I think we should consider, a couple of questions that I think we can ask if we want to really understand the differences between different types of information system. And the first dimension to consider is whether a system is based on aggregate data or individual personal data. And I'll explain what I mean by that in a moment. The second question, is it more of a strategic system or more of a frontline system? And again, in a few minutes, I'll explain exactly what I mean by that. So just starting with the first question, aggregate versus individual personal data. So this is a really important thing to consider with information systems. With aggregate, what we're talking about is just total numbers. So for example, with malaria cases, you'll just see 20 malaria cases. It might be disaggregated, and by disaggregated, we mean split into different categories. So for malaria, you might have under 5s, over 5s, and pregnant women. But we're still talking about total numbers. So we know that there are 4 cases for under 5 malaria cases here, for example, but we don't know anything more about those 4 children. We can't really drill down into the data. So it's just total numbers that are collected in an aggregate system. Whereas with individual personal data, each client's individual data is reported upwards or captured in the system. And it's important to note that personal data can mean any data that identifies an individual. Even if you remove the name, this is still likely to be personal data, as there'll probably be other information in there that you can see, like the date of birth, or perhaps the date of their visit to a facility. And these could be used to identify the patient. So it's still usually considered personal information if you're collecting this level of data on each individual. And as you can imagine, this gives you a really rich body of data to analyze. You can really drill down into the detail to understand your patients and services. But that can be a curse as well as a blessing. With an aggregate system, very small volumes of data are captured and reported. So, for example, we can see here, there are literally just 4 items of data that are collected on malaria cases. That's all that will be captured in the HMIS. For the same 20 malaria cases, if we're talking about an individual client level system, we have to capture all of these different data points for 20 individual clients. So as you can see, for those same 20 malaria patients, we're now talking about hundreds of data points that need to be captured or reported upwards. If we come back to our bird's eye view of the information landscape, you can see that the way we've laid this out, the systems that use, there's a little bar on the left there, the systems that use individual personal data are at the bottom half of the screen, whereas the systems that use aggregate data are at the top half of the screen. And this helps us start to see the differences between some of those systems. For example, an electronic medical record obviously collects a lot of personal data about patients. That's fully within the red. A tracker could collect patient information, but it can also be used, perhaps not to the same detail, and it could also be used for other things like stock deliveries or other anonymous data. Whereas an HMIS sits squarely within the green. You know, an HMIS should never, in theory, contain patient information. This is just the information that's needed for management purposes. So we don't need detail on individual patients. We can summarize it and use aggregate data for those management purposes. Likewise, for an LMIS, no data about individuals or patients should need to be collected. You know, there's a lot of data about stock, but not individual patients. Whereas a pharmacy management system, the gray box at the bottom, you can see, obviously, if that's got data on each patient's prescriptions, that's going to have a lot of confidential patient data. An HRIS, a human resources information system, sort of sits across both. You know, you'll often find in an HRIS that there's a list of, you know, it contains a database of staff in all facilities. And so the data that it contains on those staff is obviously individual personal data for those staff. But you can also find lots of other aggregate data and analysis in an HRIS. For example, modules to estimate total workforce needs. So it can really contain and use both types of data. Financial systems generally don't contain individual personal data. You know, you may sometimes find staff names or codes recorded in an accounting system, but apart from that, we're talking about very high level financial data here without individuals. And finally, a civil registration system by definition sits at the very bottom of this. You know, it contains very personal individual data on births, deaths, and marriages. But at the other end, vital statistics reporting is entirely aggregate. In fact, a lot of care is taken to ensure that individuals can't be identified in any of the analyses that are published for vital statistics. Now, if we're talking about personal data, there's a really important point to bear in mind. As soon as we start collecting personal data, things become much, much more complicated. We're now handling the highly confidential data of patients or staff, and we really need to put a lot of quite tight measures in place to make sure that we really protect this data and restrict access to it. So systems that capture personal data or report it upwards tend to be quite a bit more complex and expensive to implement than systems that collect aggregate data. If you think back to your HMIS, normally we can just give everybody access. You know, the more we share this data, the better. Whereas when you're talking about electronic medical record, we heavily restrict access to that information. Not even all doctors or nurses will get access. Often only the doctors or nurses caring for that patient will have access to the information. So I mentioned there were two dimensions, and I now want to come back to that second dimension, which is the question is it a more a strategic system or more a frontline system? And I'll explain what I mean. Strategic systems are used to inform policy, planning, management decision-making. So they're basically mostly used by managers, whereas frontline systems are used in the day-to-day delivery of services, often at the point of care for patients. So they don't just provide you with management information, they actually help you in your day-to-day work delivering services. So the implications of this are that for strategic systems, we normally only need to process summary data, aggregate data, whereas frontline systems normally process much more detailed transactional patient data. And even if it's not patient data, it might still be very detailed transactional data about accounts, or the level of data captured is much more detailed. The other point is that strategic systems are not as time critical. So for management decision-making, it's often fine if we get sent the data every week or every month in time for sort of key decision-making meetings or planning. Whereas for frontline systems, we normally need the data in real time at the point we're making the decisions. So if a nurse is treating a patient, they need to have access to the system while they're with that patient in order to see their history. If a manager's ordering stock, they need to know today's stock situation in order to be able to place an accurate order. So having set out that difference between strategic systems and frontline systems, it's important to explain that, most systems aren't just one or just the other. This isn't a dividing line like individual data versus aggregate data where you can only be one or the other. This is more of a sliding scale. So a system could be more at one end of this sliding scale, more at the other, or a mixture of both. And I've given the example here of a COVID-19 vaccine tracker, which could be used both by frontline workers to track down individual patients who haven't turned up for their second dose and need follow-up, or by senior management to monitor the overall progress of the vaccine rollout. So that really sits across both, that system sits across both of those. So to come back to our bird's eye view of the HIS landscape, if you look on the right, I've placed that sliding scale next to all of our systems. So the nearer you get to the top of the screen, the more we're talking about strategic systems. And the more you move towards the bottom of the screen, the more we're talking about frontline systems. And then obviously there are systems that sit halfway between the two or that have multiple purposes. So as we move on to the next section of this presentation, it can be really useful. Just keep in mind this distinction between more strategic, management-oriented systems on the one hand and more frontline operational systems on the other. So what I'd like to do now is dive down a little into the health services domain of our landscape and give a more detailed overview of these three specific types of systems. So HMIS, trackers, and EMRs. What we'll try to do is give you a good understanding of how each type of system is designed to meet very different decision-making needs. So keeping in mind your own country's decision-making needs, the goal here is to help you better understand which type of health information system might fit which particular need. And to start with, focusing on health services, HMOs, trackers, and EMR, to start with, we're going to look at HMIS. So as we mentioned earlier, the M in HMIS is Health Management Information System. It's very much a system to support management decision-making. But this includes all levels of management. We mentioned this earlier, from the manager of a single health facility right up to, say, the minister making big policy decisions about the whole sector. So in terms of our sliding scale of strategic versus frontline systems, an HMIS sits very, very much at the strategic end of that scale. You won't find an HMIS being used in day-to-day frontline patient care. That's just not its role. We also mentioned earlier that we were going to point out if there are some terms that maybe are a bit contested where the experts don't agree. And it's worth mentioning that sometimes some people use HMIS to mean just a facility system, just a routine facility data. Whereas here we're using the term more broadly, and a lot of people do use it that way too. We're using the term more broadly to cover all sorts of service delivery. So that includes, for example, in the way we use it here, community health workers and other service delivery. All of that comes under the banner of a routine HMIS. So where is an HMIS used? To help understand this, I'm going to show a typical health facility. We have a receptionist, a couple of providers on the left. You can see a pharmacist and a lab tech on the right. We've got our community there and a community health worker. We've got our district office with, for example, a manager, a chief medical officer, and an analyst. And we've got a national office that essentially has the same staff. So this gives us a little bit of a mini picture of our health sector. So if we look at where an HMIS is used, I've shown in red icons where an HMIS would be used in these settings. As you can see, it's often at the facility level and the community level, it's often on paper. So it might be paper forms that are sent up to the district office and everything's computerized from there. But very importantly, it's only the manager or receptionist, it's only the admin staff of the health facility that really compile and use the HMIS. Other staff use registers and other books, but the reporting comes only from that head office, from that front office. And what we're seeing increasingly is that countries are computerizing their health facilities. So they're giving a computer to help capture HMIS data. And this means they can directly capture data into systems like DHIS2. But a really important point to note here, and you can see this, is because an HMIS is a management tool, you don't need to give every staff member in the facility access. In fact, you'll normally only have data capture and management staff that have direct access to the system. And so computerizing a facility often means just giving the facility one computer for that purpose. So when asking yourself, is an HMIS the right solution? It's worth keeping in mind that changes to your HMIS can be simpler and easier to implement than rolling out a whole new system like an EMR or a tracker. Do you just need summary data for planning, monitoring, and other management purposes? Are you happy with just weekly or monthly reporting? If that's the case, then rather than a sexy new system, you might be better off just leveraging your existing HMIS. But if you do need patient level data, or if you have frontline operational needs, if you need this system to help your frontline staff, then obviously an HMIS is not going to be the right solution for you. And one final point, when you're thinking about what to collect through an HMIS, if you don't need data very frequently, for example, you just need it every year or two for planning purposes, then I think you should really consider collecting this data through surveys or other one-off data sources rather than through your HMIS. And the reason is that compiling HMIS data can be a really heavy burden on staff each month. So it's a huge waste of staff time and resources to collect data every week or every month to compile it and send it up, when in actual fact, you'll only be using that data once every year or two. And I think there's a real movement to try and reduce the burden of HMIS reporting in most countries and only really collect what's essential. So moving on to electronic medical records, or EMRs. An electronic medical record is essentially just a digital version of the traditional paper folders that the hospitals used to, and many of them still do, used to keep for each patient, stored in the archive room and retrieved every time the patient comes back to the hospital. And that would contain all of their clinical notes, all of their prescriptions, all of the information about the patient. So this is really just an electronic, much more easily accessible electronic version of that. So if we think back to our sliding scale of strategic versus frontline, this sits very much at the bottom of the scale. It's very, very much a frontline tool. It's used at the point of patient care while staff are with the patient. And it's usually quite comprehensive. It has a whole lot of different functions. It can track patients. It can, provide suggestions and care tips. So it can be quite a useful operational tool for frontline staff. Really importantly, it tracks the patient over time, what we call longitudinal data. And by tracking the patient over time, it means that each time they visit, their history and their records are available to staff. An EMR should ideally just provide one integrated health record for all of the care that a patient receives. But in practice, you might find that in a lot of GFF countries, you might find it implemented for just one program. So for example, an EMR to manage HIV care and treatment, or an EMR to manage TB care, rather than a sort of comprehensive EMR for all care. It's also worth noting in terms of terminology, the term EMR is usually used when the system is installed in a facility, and it's specific to that facility or to that organization. When it's shared more widely, it might instead be called an EHR, or an electronic health record. And you'll probably find the term EHR used just as often as EMR in the US and Europe, where a lot of these systems are much more interconnected. So I'll come back to our little diagram of the health system now to give you an idea of what's involved in deploying an EMR. And as you can see, because it's a point of care system, we now need to make sure that all staff and providers have direct access to the system as they work. And depending on the system, you may also have pharmacy or laboratory staff also accessing it, although sometimes they have their own systems too. So putting an EMR into a health facility means a lot of computers, a lot of networking, a lot of IT support, a lot of staff training. It's not just computerizing management, it's computerizing all frontline patient care. You don't normally see EMRs in the community, partly because they're a bit complex. Occasionally, community health workers might have access to an EMR, but usually they'll be given something simpler, such as a tracker, which we'll look at in a minute. And most importantly, you do not see EMRs being used at district or national level. They're a frontline tool. They have very confidential patient data in them. So we really want to make sure that national and district staff don't have access to that very confidential data. So as I mentioned, one of the problems with an EMR is that each little facility has its own patient database. So if a patient goes from one facility to another, their record doesn't follow them. To get around this, we can use something called interoperability, and I'll explain a little bit more about this later. But for now, effectively, this means sharing data between different systems. So what you might find is a tool that helps share records between two facilities here and even the community so that they can access each other's data, and that might be called a shared health record. It's important to note that this is usually just a summary. Not all of the data is being shared, just a summary. So the main patient records will still sit in each facility. The other option, which you'll hear people talking about a little more often now, is you can put the patient database in the cloud, or effectively the internet. So each health facility no longer has its own database. All of them share one database that's up there in the cloud, accessed via the internet. And all of them share the same patient records. This is great from a record sharing perspective. You can walk into one facility, walk into another facility, and your records will be there. But the problem is that your sites then need constant internet access. Remember, this is a frontline system, so you need to be able to access it whenever you're with a patient. If the internet goes down, you suddenly can't do your day-to-day patient work. With an HMIS, for example, it doesn't matter if the internet goes down for a day or so. You only need to send reports monthly. You can just catch up on data entry once the internet's back up again. But if you put an EMR into the cloud, then any internet outage is a problem, because you need to be able to access those records in real time as you work with patients. And so for this reason, EMRs are still usually installed locally in the health facility rather than being hosted in the cloud the way I've shown it here. And finally, even if your patient database is in the cloud and available over the internet, you still wouldn't normally give access to district or national offices for the same reason, patient confidentiality. So in deciding whether an EMR is the right solution for your needs, we need to weigh up, on the one hand, the fact that it can deliver huge benefits in terms of patient care within the facility. But on the other hand, as we saw with the diagram, the number of computers in the clinic, it's a big, complex and expensive project to implement. So, you need to computerize a lot of the facility. So if you're mostly just looking to improve upward reporting or strengthen your national HMIS, or if your resources and IT capacity are still quite limited at this point, then an EMR probably won't be the right fit. But if your primary goal is to improve patient care and service delivery within the health facility, and it's possible to capture data in real time as staff work, you can give them tablets or computers, then an EMR could definitely be considered as quite a high-end solution. So the final type of system we're going to look at today is trackers. Like an EMR, a tracker is a system that tracks a patient or subject over time, longitudinal tracking. But a tracker is much, much simpler than an EMR. It's often based around a specific program workflow and usually only collects a few key items of data rather than the much fuller medical record that you would find in an EMR. And it's worth noting that because it doesn't usually cover the full patient record, a tracker will often be used alongside existing paper records. It doesn't replace them. So it will just capture a few key bits of information, for example, HIV testing or malaria testing, while staff continue to do all the rest of their work on paper. And because trackers are much simpler than EMRs, they can usually be deployed much more quickly and easily. The learning curve for staff is much lower. You can quite easily install them on mobile phones or tablets. So they are much quicker and easier to roll out than an EMR. But the trade-off for all of this simplicity is that the capabilities of a tracker are much, much more limited than an EMR. For example, they don't cover the whole patient record. They might just focus on one key workflow. For example, HIV, malaria, the examples I've given, might be a PMTCT tracker. They'll focus on one particular program. And because they depend on the internet to share data, they're not very good at sharing data. If you've got two staff in a facility using a tracker, it's often quite difficult for them to share data with each other, unlike an EMR. So to answer the question, is a tracker the right solution for me? You need to consider a few different points. Firstly, do you need to capture detailed transactional data over time, particularly for your patients? If you only need summary or aggregate data, then using an HMIS might be a simpler solution. But if you do need that level of detail and you only have very specific goals, for example, you just want to track malaria or you just want to track COVID-19 vaccine deployment, then a tracker could be a great fit for that sort of need. Just with the caveat that if you have multiple staff that need to work on the same patient record at the same time while the patient's visiting, then a tracker might be too simple. You might need to start looking at something more sophisticated like an EMR. So before we wrap up this presentation, I want to talk a little about the wider context that any HIS project needs to take into account. And the truth is that your HIS solution will not be delivered in isolation. Your national HIS will already include other existing systems, and even your own solution may end up involving different types of system. For example, after considering everything we've described in the presentation above, you might decide to implement an EMR for health facilities and a tracker for CHWs. So in order to ensure the integrity and efficiency of your overall HIS, there are two important factors that you need to consider here. The first is interoperability, how these systems talk to each other. And the second is the framework of policies, strategies, and standards that exist and that you need to align to. So just starting with interoperability, because your national HIS over time will invariably end up consisting of a number of different systems, you need to think through how these will talk to each other. And really importantly, interoperability is not just an IT issue. There definitely is a very important part of it is the technical tools needed to connect two computer systems together, for example, to share data. But that's not enough. It's just as important that your systems use common standards which enable them to understand and interpret the stuff. I'll give you a very simple example. You might have two systems that are exchanging lists of health facilities so they can share data. But if each one of them uses slightly different spellings for the same facilities, then this exchange of data will be useless. If, on the other hand, you also establish a set of standard health facility codes that both systems use, and you share those when you're sharing the data, then now suddenly your two systems know exactly which facility the other one is talking about when they exchange data, and you can properly connect and understand the information the other system is sharing. Interoperability is a huge topic, and we can just only really touch on it here. But I think the important takeaway for you to think about is to consider interoperability while you're still at the design stage of your HIS solution. It's really important to think about this before you go too far down the path of developing your system. And as an example, you may find that you need to connect to a particular system, and you have a range of tools you could choose for your solution, and one of them already connects to that system. So by taking that into account at the very beginning, you can save yourself a lot of work and a lot of software development that might be needed later to connect these two systems. So coming back to that second point I mentioned about the context that's really important, we really need to make sure whenever we're working on any sort of health information systems project that we understand the policy and strategy framework that's already in place. You really need to carefully map out what sorts of policy standards are already there and really make sure you adhere to them. And examples could include health information systems policy or strategy, and which it would be very important for you to align with. You may also have a digital health strategy, or even not just in the health sector, but a national digital strategy that all sectors have to align with. So it's really important to understand what that is and to make sure that you're compliant. And finally, even talking about interoperability, if you have an interoperability framework or strategy, you may actually need to, whatever solutions you develop, may need to be able to exchange data with a specific system, or may need to use particular standards. So it's really important for you to understand and know what those standards are. So as a final point, as I close my presentation, a final point I'd like to make, and this is probably the most important one of all, is that when you're selecting a system that best suits your needs, a golden rule to keep in mind is to keep things as simple as possible. The less complexity, the lower the cost will be. The less complexity, the easier it will be for your users to adopt the system. The less complexity, the higher the likelihood that your project will actually succeed, that you'll be able to successfully roll it out. So I think as a parting note, when you've considered all of everything that's been presented above, I think probably one of the most important things to bear in mind is to try and keep your solutions as simple as you possibly can. Thank you.